Hello, good morning to you, and many thanks for joining us. You're watching Galaxy today, coming to you from Galaxy Television. My name is Justin Akadonye.
And is joined by Uche Ibekwuje. Very good morning to you. I hope that today will be more educated than it was what it has always been. Today we'll be looking at sickle cell anemia.
Yes, we will be looking at that, all that you need to know, what are the causes, if there is any, and of course what you need to do in times of crisis, and how you can help someone today. And of course, you can be a part of that discussion at this one. That is, if you really want to participate, you can send an SMS on the number now displayed on the screen, or you can interact with us via our social media platforms, Facebook, Instagram, Twitter, using the hashtag Galaxy Today. All right, we'll take a bit of a background information on sickle cell anemia, and we'll come introduce our guest here in Lagos. Stay with us.
Sickle cell disease is a group of blood disorders typically inherited from a person's parent. The most common type is known as sickle cell anemia. It results in an abnormality in the oxygen-carrying protein hemoglobin found in red blood cells. This leads to a rigid, sickle-like shape under certain circumstances. Problems from sickle cell disease typically begin around 5 to 6 months of age. A number of health problems may develop, such as attacks of pain, anemia, swelling in the hands and feet, bacterial infections, and stroke. Long-term pain may develop as people get older. The average life expectancy in the developed world is 40 to 60 years. Sickle cell disease occurs when a person inherits 2 abnormal copies of the hemoglobin gene, one from each parent. This gene occurs in chromosome 2. Several subtypes exist depending on the exact mutation in each hemoglobin gene. An attack can be set off by temperature changes, stress, dehydration, and high altitude. A person with a single abnormal copy does not usually have symptoms and is said to have sickle cell trait. Such people are also referred to as carriers. Diagnosis is by a blood test, and some countries test all babies at birth for the disease. Diagnosis is also possible during pregnancy. The care of people with sickle cell disease may include prevention with vaccination and antibiotics, high fluid intake, folic acid supplementation, and pain medication. Other measures may include blood transfusion and the medication hydrocarbamide. A small percentage of people can be cured by transplant of bone marrow cells. As about 2015, about 4.4 million people have sickle cell disease, while an additional 43 million have sickle cell trait. About 80% of sickle cell disease cases are believed to occur in sub-Saharan Africa. It also occurs relatively frequently in parts of India, the Arabian Peninsula, and among other people of African origin living in other parts of the world. In 2015, it resulted in about 114,800 deaths. The condition was first described in the medical literature by the American physician James B. Herrick in 1910. In 1949, the genetic transmission was determined by E. Ebit and J. V. Neal in 1954. The protective effect against malaria and sickle cell trait was described.
All right, welcome back from that time out. It's still Galaxy Today, and we're looking at sickle cell anemia, and we have guests here with us in Lagos.
Yes, we have Dr. Davis Nosimot Omolala, Senior Registrar Hematology and Blood Transfusion from Lagos University Teaching Hospital. And of course, Folajimi Adeboale, who is also a doctor for Wellpros Care Clinic, Magodo, all here in Lagos. Good morning and welcome to Galaxy Today.
Good morning.
It's good to have you.
It's a pleasure.
Okay, so it looks like a whole lot of people are aware of sickle cell anemia, and if you readily ask anybody, you just tell you, okay, AS and AS coming together, having a baby, then you might automatically have an SS kind of child, and they think one of the preventions is just to avoid marrying someone who is a carrier, one way or the other. But for the benefit of this program, and maybe because of some kind of maybe knowledge that isn't right, I would like you to just treat briefly what sickle cell is all about, and probably maybe the history of sickle cell.
Okay, thank you very much for having me on the show. Sickle cell disease as an entity is an inherited disorder of the blood that is inherited from a patient, from the mother and the father. So you need both the mother and the father. The presence of just one sickle gene does not confer the patient to have sickle cell anemia. However, you must be able to inherit it, one from the mother, one from the father. So you have homozygous inheritance for you to say, okay, this patient has sickle cell anemia. So just having one sickle gene does not really make you a patient with sickle cell anemia. However, there are other causes of inherited disorders that with sickle cell, apart from, though the commonest is SS, where you need to inherit, like I said, from mother and father, but you can also have some SC, SD, and SE, depending. For each pregnancy, the risk of being, even if you have a father that is an AS, an SAS, mother and father, the risk of having a sickle cell anemia child is 25% for each pregnancy. So for some, they might be AS, and they still don't have a sickle cell anemic child because each risk is per pregnancy. So if you have the pregnancy 100%, so the chances that you're going to have an SS child is 1 out of 4.
Okay, fine. So, Dr. Folajimina, so is it really advisable to just completely abstain? Let's, for instance, I'm dating someone, and we both went for genotype tests before we got married, and we both found out that we are carriers, AS. So is it advisable that we completely refrain from getting married?
Yes, it's the best, because trying to work something out with it is a risk. It's like a Russian roulette. You don't know which one comes first. You might start with the AA, you might be AS, and your first one might be SS, it might be AA, it might be the AS, you might do AS. Number 3 might still be the third AA, and number 4 might be the SS. And it might be the other way around. The first one might be the SS. You don't know. There's no particular way in which you can determine which is it. So why bother taking the risk?
Okay, but I heard something about SC. I've had a friend once tell me that probably all her life she has thought she was an AS, and then probably she went for a genotype test and she realized she was SC or AC or something. How is that different from SS? What kind of gene is that?
Normally, the hemoglobin gene, where oxygen is carried, it is responsible for oxygen to the tissues. Once there is a mutation, depending on which point this mutation occurs, just a single point mutation, substitution of glutamic to adenine, and it's just destroy the membrane of the red cell such that these red cells cannot be pliable as they move around the blood vessel. So there are other various types of mutation depending on where they occur. You have A, you have A2, you have fetal hemoglobin depending on as patient grows. So you also have S, you have hemoglobin D, you have Punjab depending on your locality. So these different types of hemoglobin disorders. So it is not just SS. So you have SC.
Okay, because sorry to cut button, because growing up in elementary biology and all of that, we were told the genotypes we had were just AA, AS, and SS. But lately I now have AC, SC. I mean, okay, so for someone who has AC, is he a carrier? I don't understand.
For somebody that is an AC, the person does not have sickle cell disorder in any form. For you to have a sickle cell disorder, you must have an abnormal S. However, for those that have hemoglobin C, Punjab, hemoglobin E, you have sickle cell, you have hemoglobinopathies, that is disorders of these hemoglobin genes, but not necessarily you have sickle cell disease. However, once you have an abnormal hemoglobin and you are now having another hemoglobin, which is S, that means you have two abnormal hemoglobin genes, then this patient is prone to more crises and diseases as a result to inability of these red cells to carry oxygen to the tissue.
Okay, so I'd like to paint out a case. I mean, about 2 years ago, something happened to a neighbor, lost her child, and I think that was when she had to go for a test. I think it happened in Louth, and it was realized that she and her husband were actually AS. And so a closer look I saw, or maybe noticed, maybe I'm wrong, looks like the second child could actually be SS because the one that died was SS. Now, I'd like to ask, at pregnancy level now, as an SS, I don't know if I should call them patient now, as an SS patient, what's the risk of pregnancy if a woman who's SS is pregnant? Is it even advisable as she goes through the journey of pregnancy?
Okay, let me take you back a bit on some basic things. We have AS and we have SS. Now, the AS person is just someone who has a sickle cell trait. He doesn't have all the sickle cell, anemia, or the disease or the feature. However, if being autosomal recessive, if you bring one AS and another AS together, the child inherits half of this, half of that, and he has the full-blown sickle cell anemia, which is the SS. Now, SS can have successful pregnancies. They can live normal lives if well taken care of. They just have a lot of problems. They might have, they are prone to a lot of diseases and illness. Their pregnancy is actually still categorized as high risk because there's what we call vaso-occlusive crisis, which is actually part of the problem of the red cell itself. When the red cell begins to sort of get the shape sort of changes to form the sickle shape, and it's really not a functional cell anymore per se. The oxygen carrying capacity is very, very low, and issues like that do arise. So from that point, you need to take care of somebody who is SS. You need to keep an eye on that person, the nutrition, the activities, and the pregnancy also. So all these things are quite important for them.
Okay, all right. We'll come back to Lagos in a bit. Let's just quickly go to Ibadan right now. We're also being joined by Dr. Oladapo Warranty, Senior Registrar, Hematology Department, University College Hospital in Ibadan. Many thanks for joining us, Dr. Oladapo. Okay, let's just get straight to it now. For instance, the harm has been done, and AS got married to an AS, and they have a child who is SS. So how do you begin to manage and care for this child? For instance, there's this myth and this rumor that most children who are who has sickle cell, they don't live for that long. How true is this?
Good morning, thank you for having me. I want to appreciate you for the privilege and for considering sickle cell disease or sickle cell anemia as part of what you are discussing today. Patients with sickle cell, children with sickle cell anemia, the world has actually gone beyond what we are doing in Nigeria. There is an aspect of neonatal screening which make them to diagnose sickle cell patients as early as possible, and they can be well taken care of before age 5. And this subsequently affects their way of life and the prognosis of the disease. But in Nigeria, they are not diagnosed at neonatal stage. Most of them actually came to the hospital at the point when they have one issue or the other. Most of them came in with infection. And the most important thing is the prognosis of the disease depends on the kind of health care that the patient gets from the managing physician. So this kind of opportunity we allow people to know that neonatal screening is what is available and what is best for our patients now, and this will help them achieve near normal life in their undertakings in life too.
All right, so invariably you're telling that you might not be able to tell immediately if a child, when a child is born, that he could have the traits and the SS and all of that, okay? But then again, so invariably, should these children be given special attention, specifically when they are growing up? Well, I remember correctly when we were in secondary school, we had this student who was diagnosed with sickle cell anemia, and he was not allowed to do chores. He was not allowed to do most things other students would do. Is this normal? Should there be some sort of discrimination for people who have sickle cell?
It's not supposed to be a discrimination, but it needs to be attended to in a special way as part of modifiers of this of the disease. Exercise, stress actually affects the outcome of sickle cell disease. So they need to be well taken care of. They need to be on some special drugs. They need to be on they need to be seen in clinics, and they need to reduce their activities, the stress they undergo at school.
All right, we'll try and reconnect with Ibadan shortly. Let's just speak to our doctors here in Lagos. He was talking about special attention and special drugs. Are there like routine drugs sickle cell patients should take, like pregnant women would do?
Yes, the advent of treatment of sickle cells have evolved in the last year, and patient care and patient survival has actually increased significantly in Nigeria, even though we have one of the highest burden of sickle cell anemia in sub-Saharan Africa and West Africa. So patients with sickle cell, because of this, the fact that their red cells are constantly being destroyed, they tend to produce more red cell, and that means they are using up their folic acid in the production of this red cell. So routinely, these patients are given folic acid because of the high rate at which their blood are being destroyed and new ones are being formed. You also want to prevent them from having malaria, especially since we are in the malaria endemic area. You need to give them anti-malaria, paludrin, prophylaxis. You don't even want them to have malaria in the first place.
Why not?
Because already they have low blood level because their cells are constantly being destroyed. So having them having malaria, even though they don't usually have that more symptoms for a patient that is AA, the malaria, but you don't want them to have malaria, and you want them to take a lot of water, because what actually precipitates most of this crisis, dehydration. The cells are not moving well, they are close together, they block. Once they block a blood vessel, the blood is not supplying to that vessel, so they feel pain, they are constantly in pain. So you want them to, take a lot of water regularly, at least 3 liters in a day, so that these bloods are flowing easily and everything. So routinely they are on those folic acid, paludrin, and vitamin C also helps in the absorption of these drugs, and a lot of water, and to avoid stress.
Okay, so knowing that in recent time there's this belief, or let's say that a whole lot of people felt like what we called Ogbanji was actually sickle cell people who died, and maybe because the parents were carriers and they keep giving birth to this set of people. But has science gotten to a stage where there can be, maybe not the permanent cure yet, but at least to make them, because there's this belief that they don't live long. Well, has there been anything done that could make these people exceed whatever? I don't know what the age range is for them, but has there been anything done to say that they live longer than that and probably have a normal life?
Well, it's first of all, they live long now. I've seen people with sickle cell disease 50 and above. But in some people, the features of sickle cell disease may not even show until later in life, because we have what we call the hereditary persistence of hemoglobin F, which ties them through their childhood. So before you even know that they are sickle cell, they have sickle cell anemia or sickle cell disease, they are more or less into their adulthood, and the number of crises, the number of issues they have is really scarce in between. They really don't have much issues per se. So based on those facts, based on how well they are managed, based on nutrition, there's a very, very good chance that they can live long.
Okay, so invariably, you could be sickle cell anemic and you don't even have any symptoms at all.
It depends on the stage in which they are in. They could have symptoms. The issue is that the occurrence might not be. You could have people who fall ill every 3 months. You could have people who barely fall ill once in a year. And all these things matter on the long-term basis for them.
Okay. So what's this thing about the yellowness of their eyes?
Okay, let me quickly add, in as much as patients have sickle cell anemia, there's this thing that really confers them, even though you have different patients, both have sickle cell anemia, they present differently because there's some of genetic modification in each individual that predispose this person is going to have more crisis than the other, even though both of them are AS and SS. And we have studies have divided it as whether they have the hemolytic phenotype or they are not the hemolytic phenotype. So patients that usually have the hemolytic phenotype and usually have low blood levels and usually have more crisis.
Break it down again.
Okay, it means that it means that for some patients that are sickle cell, some will like their blood more, while some would not like their blood more. That means once their blood keeps lysing, as in their blood keeps reducing, it keeps breaking because these bloods are rigid because of this deformity. So these bloods are being destroyed. And once blood is being destroyed, the hemoglobin are released. That means the body is also trying to mop up this hemoglobin. That is when you have this yellowness of the eye. So it's an indication of the rate at which the blood is being destroyed in the body. So, but for a patient that have the hemolytic phenotype, that means it lyse blood more. They are more prone to having crisis more than those that don't lyse their blood more, and also depend on how their survival rate is.
Okay,
for those type of patients.
Let us still break it down.
Okay.
You talked about crisis. To most people, crisis means different things. A crisis could be like a very chaotic situation. Now, speaking of crisis for sickle cell anemia, what does it really entail?
It means normally at the base level, normal sickle cell patients break down their blood levels regularly because of their disorder. But when it is now more than necessary, then these patients are said to be in crisis. That means their blood levels, their blood are breaking down more than the other. So their blood are being occluding the vessels more than the other. So this patient presents in pain. So you have, depending on where these blood are blocked, these vessels are blocked, patients present with different type of crisis. You have the painful crisis where these patients are constantly in pain. And when you even rate this pain, you're talking about up to 9/10 as in the severity of this pain. This pain might also affect the chest, and this is an emergency, and this patient, you'll be thinking this patient have an acute chest syndrome. That means the blood vessels are blocked in the chest. This patient cannot breathe well, and this patient can die in minutes if attentions are not given to this patient. Also, this patient can pull blood into the spleen. This spleen is what helps you to fight infection, try to sort out blood. But somehow, this blood, sickle cell, block these vessels, and this patient blood pool, the complete blood in the body just pool in the spleen, and this patient is in shock and can die. Patient can have leg ulcer. You just find somebody, this wound on the leg is not healing just because a patient has a sickle cell ulcer, and this is no matter what you do, this cell is not healing. Then also you can also have priapism, which is commoner in males, even though it also occurs in females. This patient have a persistent erection without any stimulation on arousal, and it is so painful for patients that have sickle cell, and this patient might sometimes require surgery just to relieve this pain.
I'd like to know what else are they prone to? I mean, are they? Is it a kind of disease that is open to welcome any kind of sickness like seizures and the rest? Are they prone to anything?
No, primarily they have issues. They're not, like she said, they have issues with healing in the extremities. In babies and adults, they could also have bleeding to the brain. They're a bit prone to stroke also. Yes, they're a bit prone to stroke. And if the primary problem with them actually is this vaso-occlusive crisis. because the blood flow will be hampered in a very, very painful way. The blood is not flowing, and at that point, there's no oxygen. So there's a lot of pain in those joints, in those knees. It's what it really prevents them from doing is they can't really undergo much stress. You don't expect them to do exercise. You don't expect them to be involved in sports because they might easily get dehydrated. Okay. Then they're also prone to splenic infarct and splenic abscess, in which the spleen sort of loses its function, and the spleen has a role to play in terms of immunity, which will now later lead them to having antibiotics or taking some drugs or some vaccination from time to time.
Okay, let's talk about the rate now. I mean, this has been, I've known sickle cell since when I was maybe primary school. I've had classmates who were rushed home here and there, and I was thinking growing up that it would have reduced. If we look at it from the, okay, I don't know when it was confirmed in Nigeria, when we actually came to know, until now, is there any reduced rate, or is this still something we are still combating here in Nigeria?
Yes, the 2015 national guideline on sickle cell management puts that at least 24% of Nigerians have this sickle cell trait, so it is still a problem.
But as against, before now, it used to be more.
It used to be more. Okay. As against now, there's still an increase, but what we found out that there's better care. So these patients don't tend to die, then you'll be having Ogbanje, Abicus, that exactly. Is So, but because of good care, these patients are living much better. Diagnosis is early, so their survival rate is a bit higher. And because of this treatment that have been developed, these patients tend not to have as much crisis as before, but it's still there. We're still endemic, and we still need awareness for people to know their genotype before going into relationship.
Okay. Okay, but before we go, I just want to also talk about growth. Does it in any way affect their growth? I've seen some sickle cell patients who looks healthier than I am, and then they are SS. But does it in any way affect their growth? Maybe in any way, does it?
Physically, they may be stunted.
Okay.
Especially if they keep having these issues from time to time, it could affect their growth. And just like you said, for some people, you will have no idea or no physical feature. There's actually some kind of feature you see on some people, and you can identify that this person has sickle cell disease. But in some others, you don't even see it at all.
Okay. All right, Dr. Oladapo is still standing by in Ibadan. Let's quickly go to them there. Doctor, let's talk about the severity of the disease. At what point could it be that serious where blood transfusion could be necessary?
Okay, in sickle cell disease patients, they actually have steady state hematocrit level. Their PCV is actually, they have a steady state PCV. But when they have hyperhemolysis, or what we call hemolytic crisis, there is increased breaking down of that red cells. Subsequently, the steady state the PCV will drop below the steady state. And it is said that any drop that is 3% or greater than 3% of hematocrit level, the patient needs to be transfused. You see these patients, you notice that their eyes become more yellow, and they'll be passing dark colored urine. Some of them may not actually have increased jaundice, but that doesn't mean that there is no hemolysis. So when there is reduction in hematocrit level, 3% or more than 3% below the steady state PCV, the patient needs to be transfused. And in sickle cell disease patients, vaso-occlusive crisis, as said earlier, and there is hemolytic crisis. It's been said that there are some patients that are actually predisposed to this hemolytic crisis. They have recurrent hemolytic crisis compared to the other set of patients that have more bone pain crisis. So any reduction in hematocrit level will subsequently needs to be reviewed, and patient may need to be transfused. Any reduction in
correctable is there. I mean, looking at blood transfusion now, I don't know if it's like if there's something one can do to help manage this, like more like if there's something in them that can be put in to correct something. I'm talking in the aspect of surgery. Is there surgery that can be done that can correct one or two things?
hemolytic crisis, as long as the patient is symptomatic of this anemia, patient needs to be transfused. There are no other ways to prevent hemolysis. There are new drugs now that's being said to like hydroxyurea that has been talked about initially. There are drugs that actually to stabilize the patients, to increase the fetal hemoglobin.
All right, that was Dr. Oladapo Awarati from Ibadan. We lost that. Okay, let's go back to Lagos studio. Right, we're actually looking at, you said something like the severity of it. Does it get to a stage where they need blood transfusion? And I'm like, if it gets to that stage, is there any other corrective measures, maybe what surgery can do to help a sickle cell patient?
Okay, you see, first of all, you see, the average lifespan of our normal red cell is like 120. They have theirs could be as low as 20 or 30. So they are actually deficient of functioning red blood cells. And in the crisis, red blood cells actually get destroyed. Okay. Much more than even what they have before. So the best thing you can do for them is blood transfusion. Okay. So you will get far better result than any other option in the immediate relief of the issue. And you must also realize that blood is very central to breathing and respiration, to bring them out of shock. It's the primary carrier of oxygen. And if red blood cells is not carrying oxygen effectively, that person cannot even stand up or do anything per se. So which means that at pregnancy level, one who's a mother who has probably is pregnant with a sickle cell baby and consumes so much of folic acid, are you saying in a way could that help the baby? Because I know that early stage of pregnancy is expected for the woman to take lots of folic acid. I'm not talking about the carrier now. I'm talking about the woman who has a baby who is sickle cell but still in the womb at this moment. If she consumes so much of folic acid, will this in any way help the child?
No, what the role of, we should try and understand what the role of folic acid is in the baby and in the mother. What sickle cell and what folic acid does in the baby is to help the formations of the nerves, neurons in the baby. And so taking folic acid primarily in patients that have sickle cell disorder is such that because of the rate of which this blood has been destroyed, you want to help the body to be able to form new red cell. That is what folic acid does in a patient that isn't. But what happens is that babies in pregnancy, because they have very high fetal hemoglobin, as we're born, we have different types of hemoglobin. Some are predominant when we're in the belly. As we're born, they keep changing until we form these adult hemoglobin. So babies are usually protected up to the 6th month of life for in utero because they have very, very high fetal hemoglobin. So they don't tend to have crisis. You don't really know. But what happens is by the time they are from 6 months, they are transiting, then that is when this fetal hemoglobin is going down, and then patients start having those crises, the Anderson syndrome that you showed and everything. And that is what this hydroxyurea, the drug hydroxyurea, is trying to do, is to increase this fetal hemoglobin level, because we found out that with the use of hydroxyurea, it helps to bring up the fetal hemoglobin and tend to confer some immunity on this patient. So their rate at which they sickle is reduced. So that is why hydroxyurea is used, because it tends to increase the fetal hemoglobin.
And in all of this, could there really be any need whatsoever for maybe bone marrow transplant?
Yes, a patient, you need to also, patient pregnant, you can detect whether they are sickled as early as 14 weeks of gestation. There are studies that you can show. So it's either you want to terminate or you want to proceed to have this child. And when this child is born, depending on, you need to classify, does this patient have very severe crisis, or this patient can just live a normal life with hydroxyurea or routine drugs, the folic acid, the paludrin, and vitamin C. Or this patient has crisis that this child is prone to stroke, because you need to monitor this child from birth to know whether this child is prone to stroke, this patient having a lot of crises and everything. Then you can do a stem cell transplant, which confers, it's a cure for sickle cell. And it is being done. I think one was 3 have been done in Nigeria.
Successfully?
Yes, successfully by Dr. Bazwa in Benin. And so these patients tend to live near normal life. They are AA because they've gone to stem cell transplants offer cure for patients with sickle cell.
But like how old? Can it be done for an adult as well?
No, it can't be done for everybody. Like I said, you need to, it's expensive. You also need to tell if a patient can just need, I mean, normal life with routine drugs. Why do I want to subject this patient to transplant? Because transplants, because of the drugs they're going to go through, sometimes patients die just preparing this patient for transplant. So you really need to decide which patient do I want to subject to a transplant or not. So you need to decide as a clinician what a patient you want to subject to a transplant.
I know, but I'm saying, does it have an age range?
Early for now in Nigeria, I'm 16 years cut off for now. Okay. But of course, in developed world, they might go.
I need to
higher.
understand something, Dr. Folajimi. In this case, for someone who has this SCD, so for me, it's the term I'm going to use. It's like a sentence into a lifetime of drugs, one. And secondly, is it something you can actually outlive? Because we've had myths that after a particular age, you will not have it anymore. So how true is this?
First of all, genotypes don't change for life. If you were born it, you stay so for life, unless you go through a transplant. You understand? That is what can teach you. But you can't just live. Just like asthma, you feel you can outgrow it. It doesn't happen. However, you can actually have reduction in the number of crises you have per year. You understand? So that is that one is on its own. You can't change by any means except by transplant, which, like she mentioned, is a process in which they have to sort of like bring down the person's immunity, bring in some new cells. It's a whole process on its own. That is the only way you can do it. But for you to think that you can just outlive it or something happened, a miracle happened. Some other problems some people do have is when they were misinformed by a laboratory error. You understand? That also creates issues with controversy. I did this test 3 times. They told me twice it was this. They told me now it was this. You understand? But beyond that, there's no way which people outgrow it. Then concerning the issue of being sentenced to a lifetime of drugs, I wouldn't want them to see it that way, because there are so many other illnesses that require taking medications on a long-term basis. And primarily, it is not a problem. We just bring in culture and belief and faith into it, that it's a burden. As long as you just pop a pill, we take food every day. We never complain that food is a lifetime of burden for eating. You understand? So why should we complain of taking little pills which will prevent diseases and illnesses? So and this thing comes into patients' adherence and compliance to drugs. Because we try to encourage them that do not see it this way. They begin to bring in faith into it. They begin to bring in, why me, why not the other person? So we don't want them to look like, oh, it's a lifetime of burden. It's a lifetime of I'm carrying a curse or something like that. They can live well. They can take care of themselves well within reasonable means. They can go ahead and get married. They have to find an AA though. They can't even marry an AI. They have to make sure that they have to put their touchlight out there very well and get married to a compatible mate.
All right, it's still Galaxy. Today we're looking at sickle cell anemia. We'll take a very quick break. We'll come back. We'll take some of your questions and your feedbacks in a moment. Stay with us.